Okay, hello everyone. So I hope you can see my slides. So hello everyone around the world. A warm welcome to our webinar winter session today. That is all again about fetal cardiac MRI fetal cardiac imaging using MRI. So please know that this session will be recorded as we will upload the recording on our website within the next few days. So today it will be Fabian and myself, Leah. I think for some, I'm a new face at Northth Medical. I'm guiding you through this webinar session at the end of the year. As always, this is a webinar session here to connect, exchange, and learn. So you're all very welcome to actively participate and to discuss during this webinar. Just please simply raise your hand if you want to speak, or you can just also ask questions in the chat. Most of you also are aware of our magazine, which contains the latest news from the world of fetal CMR. So there are already 2 issues, and we are still in the making of our 3rd one, which will appear in 2026. So if you have a contribution to make, share images, then you're very welcome to share this with us and to connect with us. So we are always looking for some insights and some input from you. This winter session today will focus on development of fetal cardiac MRI as well as future outlook, but also practical application and clinical case insights. And this is the last and 4th session of this webinar series in 2025. So today I will be starting with a presentation on the development and future outlook of fetal CMR, followed by Domenico, our MRI application specialist, who will take a look into the clinical application side, showing how to assess coarctation in fetal CMR. And finally, I'm very happy that Dr. Prashant Minocha from Ochsner Health Center for Children will show real clinical cases as the last speaker today. So let's just directly jump into the next 15 minutes where I will be talking about the development of the already 5 years of fetal CMR and also taking a look into the future. So I'd like to start with this great graph from Desmond et al. From Los Angeles, demonstrating the proposed clinical pathway for prenatal imaging in CHD. So this graph will guide us through the next slides, showing here at the beginning, of course, of a pregnancy that the patient will do a screening ultrasound followed by a fetal echo when there are risk factors or suspected CHD. And now then at this point here on the 4th point, an additional fetal cardiac MRI can be performed, which can provide complementary information as a differential imaging tool to positively influence the neonatal outcome. So of course, echo is and remains the gold standard in prenatal imaging, but it also has some limitations. So fetal echo becomes less applicable as the pregnancy progresses. The rates of prenatal detection of CHD using echo vary from 42 to 82%. And of course, this can have different reasons from different expertise of the clinicians doing the echo, or also the specialized centers, or even operator dependent limitations. We also know that fetal echo itself has some limitation when there's a lack of amniotic fluid, an increase of bone calcification, unfavorable fetal position, or maternal obesity. And this can lead to discordances in pre- and postnatal diagnosis of CHD in up to 90% of cases. And now to give an example, in practice, the aortic isthmus is one of the most underdiagnosed conditions prenatally. So only 21 to 50% of coarctation is diagnosed prenatal with fetal echo. So this will also be the talk of Domenico, clinical application-wise, showing how to best image coarctation. So now, 5 years ago, there was no real-time second-line imaging tool for differential diagnosis before birth. And now with SmartSync, a whole new perspective becomes clinically available. So here on the right, you see the external Doppler ultrasound gating device, which is called SmartSync, which makes it possible to show or to generate such images, which are here from Professor Gorincourt from Clinique Bouchard, Marseille. And this is a complement second-line imaging tool, SmartSync. So now, first, I would like to start with a quick poll asking you if you're already using SmartSync. So there should be a poll appearing now. Second. I hope you can see it in your chat. Feel free. So I think you can see it, right?
6 answers now, 10 answers. Use twice is also good.
Okay, great. There's already a lot of answers, almost, okay, now 65% already using SmartSync, 35% not yet, but maybe hopefully in the process of starting. Of course, it's always really interesting for us to understand who's participating here, but whether you're new to the field or already an expert, this webinar, of course, is intended for everyone who's interested in fetal cardiac MRI. So thank you for your first activity here. So let's further jump into the next slides. So now, how do we know about also, of course, now the impact of fetal CMR? So now we're looking state of the art. In the last 5 years, we've established a fetal CMR community with a total number of 92 devices in the global market. With 23 countries, a lot of them in Europe, North America, starting in South America, but also now Asia. And of course, with an increased number of devices in the market, there's also an increase of scan activity. And the statements about feasibility of fetal cardiac MRI are clear. So from 589 scanned fetuses from 22 publications, we clearly see, and these show that performing a fetal cardiac MRI scan with SmartSync shows a high feasibility rate, with an overall of 90% of cases where fetal cardiac MRI was successfully performed, highlighting some reliable heart rate detection with a high sensitivity of 96%, and also reliable visualization of cardiac structures with ventricles and atria achieving the highest delineation scores. So last year in 2024, in September, there was a scientific survey done in collaboration with Professor Gorincourt from Clinique Bouchard in Marseille, with 30 participants with different time of experience, just started or also experience for a couple of years. And the first insights show that 80% recommend the use of SmartSync, and also here the majority are using it for clinical as well as research purposes. Here I'd like to highlight some facts regarding the application itself, such as transducer application, scan duration, or positioning of the mother. Also, since Domenico has joined us 2.5 years ago now, he already supported 52 centers worldwide. And here in this context, I would like to highlight this great multi-center study between University Hospital Bonn, Children's Hospital Colorado, and Phoenix Children's Hospital, with a very high number of participants of 98 fetuses, which have been included, demonstrating which factors lead to the best image quality, and looking, for example, at factors for gestation and age, positioning of mother, or even breathing techniques. So looking at various publications, survey, and also the second fetal cardiac MRI expert meeting in Hazelwood today, we learned what the most common clinical indications are. So in general, indications include various complex CHDs, and in cases where echo is challenging, as we said in the beginning, for example, at late gestational ages. And we know that the most common pathologies clinicians are looking for when evaluating the aortic isthmus, so coarctation of aorta, for example, prediction of uni or biventricular outcome for borderline left ventricle, HLHS, heterotaxy, cardiac mask, AVSD, also congenital diaphragmic hernia, TGA, and also abnormal pulmonary arteries or veins. Of course, it's crucial to have information on the diagnostics of fetal cardiac MRI, and studies have shown in the past that fetal cardiac MRI shows a comparable diagnostic accuracy to echo. And we looked from 2021 to 2025 at 16 publications showing in 278 scanned fetuses that fetal CMR can be reliably used for diagnosis. Highlighting some results, fetal cardiac MRI correctly assesses CHD in 91% of cases. Here are some highlights from studies showing high sensitivity and specificity, that fetal cardiac MRI has a clinical utility due to additional diagnostic information and affecting patient management and or parent counseling in 84% of cases, which were 26 from 31 of all cases. Fetal cardiac MRI can provide diagnostic information when echo fails to determine all relevant structures, and also lastly allows to see a comprehensive assessment of associated congenital disorders, as we know that congenital heart disease is most of the time not isolated. Looking again at the answers from the survey, over 70% of the participants see a high value of CNA MRI, and here on this one, the half sees an improvement of fetal cardiac analysis with SmartSync. Here we gathered some statements from experienced customers, such as Dr. Lorna Brown from Children's Hospital Colorado, highlighting the benefit of seeing the fetus's anatomy in 3 dimensions, which really helps to make a diagnosis, and also from Professor Salomon from University Hospital Paris-Neckar, who underlines the complement of fetal CMR to echo. So now, as I said, we know that fetal cardiac MRI provides comparable diagnostic results to echo, but what can fetal CMR add on top of that? So looking here now at 4D flow, where we can have a deeper look. So there's also really high diagnostic quality achieved in 4D flow. It was successfully used to evaluate fetal circulatory hemodynamics and quantification. Also, there is an added value compared to CNA in about half of the cases. And 4D flow has the potential to characterize flow patterns in CHD subgroups, such as in HLHS or TGA. Also, strain analysis studies performed with fetal cardiac MRI have been very promising, also with a high successful rate, showing distinct differences between healthy controls to specific CHD subgroups, and the clinical impact shows, or there's the potential of differentiation between fetuses with and without CHD, having an added value in evaluating fetal cardiac function and identifying CHD. And lastly, study on reference values for fetal cardiac MRI dimensions in healthy 3rd trimester fetuses. This was an establishment of fundamental clinical data, calculating the ejection fraction and left and right ventricle function. So there were no geometric assumptions, but direct measurements. So there is a more accurate, potentially more accurate volumetric volumes compared to echo, with up to 40% higher values. So those findings agree with the neonatal MRI data supporting the reliability. And also for those 3 topics, the clinical impact and feasibility needs to be studied in more detail. Here again, some statements from Dr. Friesen, also from Children's Hospital Colorado, and Professor Lütkens. They both state the potential for deflow, which allows the comprehensive visualization and quantification of hemodynamics in the fetal grade thoracic vessels. So now looking at the graph here again, which I mentioned in the beginning, we are here now at this stage of looking at the outcome of the neonatal outcome. So fetal CMR can add additional information which influences parental counseling. So this makes the parent comfortable also in decision making. Delivery planning, so where and how does the baby need to be delivered? Looking at also it affects early postnatal care, so targeted decision on need of medication, intervention and surgery. And also lastly, we hear more and more often also the effect on an efficient resource management, also now the targeted use of staff, equipment and beds if the diagnosis is clear. So we want to answer the questions, where does the baby need to be delivered? How does it need to be delivered? And what does the baby need immediately after birth? Taking a look again at the study, at the survey, almost half of the participants already experienced impact on diagnostics or treatment with SmartSync, and the other half not yet there yet, but this is also some statements confirming what we've seen on the slide before. So looking at post and prenatal influencing the path. And our user Malenka Bissell from University of Leeds is also supporting the clinical impact of SmartSync, looking at the risk stratification in TGA, which helps to answer really questions if the baby needs to be delivered in a specialized clinic, and also what immediate postnatal care is needed. So the last slide, looking into some future directions, we see to the improve for image quality at centers using SmartSync. That's why we also have the great support by Domenico, who will then connect on this presentation. And next to that, having a deeper look into the evaluation of the clinical effects. So we know of the clinical impact, but not also looking at clinical benefits, but also economical ones. And of course, the whole Northh medical team believes in fetal cardiac MRI. And so does the survey participants. 80% of them see an input of fetal CMR in the future. So now, lastly, my question is again to you, how do you assess the use of fetal cardiac MRI with SmartSync? So I started another poll. So do you see fetal cardiac MRI always only as research tool, only research but willing to use it for diagnostics in the future, only in specific cases, or even a standard clinical examination? So I'm waiting for some answers, but it's great to see, and what of course we also believe in, fetal CMR as a standard clinical examination, which can add very important complementary information next to echo. Great to see, very interesting. Some more and more answers are incoming, but I think this gives us a really great overview and feedback also from your side. So thank you again for participating. This is always a great opportunity, of course, for us also to exchange with you.
But also people can answer who are not using SmartSync yet, right?
Of course. It's not only people, also what you think when you're not using the device SmartSync yet, where you see fetal cardiac MRI. Okay, great. So thank you for this. And now we came to an end. of my presentation, and I would like to thank you for your attention so far and like to hand over now as our next speaker to Domenico, who is...
Maybe if there are questions from the audience,
yeah.
Maybe you can put them in the chat, questions for Leah, questions
course.
on how we see that, how do you see that? So if you have comments, we can also unmute you. So I think we have 5 minutes. We can also have that at the end of this webinar for discussion.
Yes.
Because we're always interested in what you actually think. If we don't see something in the comments, then of course Domenico will continue and we'll see if we have a discussion at the end.
Yeah, of course.
For us, having this for 5 years now as a tool in the clinic, it's of course super interesting to understand what is happening with this new feature and where do we need to or can help and support, and also our activities are, needs to be directed somehow. So your input here is super valuable. We just can try our best, but without your input, it's very, very challenging. So we really appreciate all of your input every time.
Okay, so hi everyone, I'm Domenico, and thanks for the introduction, Leah. So here now in my presentation, we go a bit through on some tips on fetal cardiac MRI, and here for assessment of the aortic arch in cases of cortection. And okay. So in this case, just an overview, this is a work that coming from also a guideline that we just prepared, and it's a step-by-step workflow has been created to help clinician and MRI technician to optimize planning and interpretation, facilitating the detection of cortection and hypoplastic aortic arch. It also aims to promote consistency across center, provide practical guidance for daily clinical practice. And in this application guide and these slides, we will cover the pathophysiology and drawing inspiration from also the ESOG practice guidelines and fetal cardiac screening in ultrasound. We will emphasize the importance of becoming familiar with the axial view also in fetal CMR. We will then discuss the fetal CMR planning protocols, the sequences to be used, the method to visualize the aortic arch, and finally the anatomical variation. So here, I don't want to give you a lesson of anatomy, but cortection and cortection of aorta and hypoplastic aortic arch are among the most frequently fetal aortic anomalies and often associated with ventricular disproportion and abnormal flow distribution. So, and here we can see the narrowing of the aortic arch, most often near to the ductus arteriosus. Here is a slide showing the normal fetal heart, and MRI typically show the aortic and the pulmonary outflow tracts are similar in caliber, and the aortic arch show a smooth and therapeutic course. MRI flow sequences demonstrate laminar asymmetric flow through the aortic arch and ductus arteriosus with no evidence of narrowing of turbulence. So as you can see in the MRI images on the right. Here it's the fetal cortection of the aorta. MRI typically show the ascending aorta, transversal arch, isthmus appear hypoplastic or narrowed, while the main pulmonary artery is relatively enlarged, and flow imaging reveal reduced or turbulent flow through the aortic isthmus and increased ductal flow. And here, as you can see in the imaging of the aortic arch, you can see the narrowed aorta, and on the right side, an MRI images of hypoplastic aortic arch. Now we go through the anatomical reference. So here I just also put this reference from the ESOG screening guideline because I think that a clear understanding of fetal cardiac anatomy and the standard echocardiography screening plans is essential before planning targeted fetal CMR acquisition. And these are the 5 axial plane recommended by ESO guideline for optimal fetal cardiac screening. if we transfer the principle of echo-fetal cardiac screening into MRI, we work in a similar way. And I want always not to highlight that, because I think it's also really important for the technical side, because it's really important to see exactly how it is the anatomy of the fetal heart. And in this case, if we transfer that on a fetal cardiac MRI, we are using a full stack axial cine sequences to reproduce specific key planes, allowing us to assess fetal cardiac and great vessel morphology and function with comparable systemic coverage. And the key reference view for cardiac MRI planning are 4-chamber view, RVOT, 3-vessel view, and 3-vessel trachea view. So, and in the middle, we have the images of fetal axial cine full stack. And these reference planes guide the correct orientation for targeted sagittal cine imaging of the aortic arch. Here below are the most important images view used for planning the aortic arch, the sagittal view of the aortic arch, pseudo 4-chamber view, RVOT, 3-vessel view, and 3-vessel trachea view for accurate aortic arch planning. Now we go to the third part, so where we are talking about the fetal CMR aortic arch planning protocols, and this protocol provide a structured approach for fetal cardiovascular imaging with a specific focus on the aortic arch and great vessel, and below an overview of all possible sequences used in fetal cardiac MRI, highlighting those that should be prioritized in a protocol for suspected correction of aorta. Of course, we can do black blood imaging, white blood imaging for the flow, cine. We can do mapping, T1, T2 mapping, Q-flow. But of course, in the case of protocol of correction, I will follow like the following steps. So survey, black blood images for fetus localizer, axial, coronal, sagittal, T2 single shot, 4D flow images, sequences, and then the cine axial full stack and the cine sagittal full stack for the aortic arch. Here we go just through the workflow and the protocols, just to provide a structured approach for fetal cardiovascular imaging with a specific focus on that, on the aortic arch. And the protocol begins, as I say, with a maternal localizer and a fetal localizer, and to establish fetal orientation, transducer position, and fetal heart also position. So the protocols continue with the 4D flow sequence planning for comprehensive hemodynamic evaluation. Why it's one of the first sequences? Because the fetus can start moving, can be more active. The mother also can be tired soon. So, and how to plan the 4D flow sequences is just to try to get parasagittal view of the fetus covering the whole heart and with extracardiac vessel. Here, just I want to show a really beautiful recent article and publication for Bonn that show really how 4D flow is clinical feasible in the 81% of the fetus in this case of this article. I know that, of course, it's not always available on all the scanner, but 4D flow it's a really feasible sequences. So then the workflow then moves to the axial full stack cine, and for global heart morphology and vascular assessment, it's exactly a full stack axial of the thorax of the baby. And once acquired, you can plan your examination and the following sequences on your preference. So after acquiring the cine full stack images, we scroll through the slices cranially to identify the pseudo 4-chamber view, the 4-chamber view, and then a 3-vessel view or RVOT, and a 3-vessel trachea view, which are essential for accurate aortic arch planning. Then continues with the cine sagittal full stack planning, which is crucial for a comprehensive assessment of the aortic arch in suspected correction. And in this case, I will explain the two methods in the following slides. As we can see in the images from the left to the right, we have a pseudo 4-chamber view, RVOT, and then the 3-vessel trachea view. So after acquiring the aortic arch, target sequences may be added in if needed. For example, in this case, the Cine short axis full stack sequences can be also acquired if needed to calculate the ejection fraction. This is how to plan, of course. And here just an overview from the left to the right of the sagittal view of the arch, the short axis, and for chamber view. Now we go through the method. So as also like it's possible to do in, we just following a bit the guideline of the pediatric cardiac MRI, and this is the step-by-step Cine planning. And we have the first method that plan the Cine on the axial full stack view, and in this case position the slice through the middle of the ascending aorta and also in the middle of descending aorta to get the aortic arch. The second method is to plan always of the Cine axial full stack view. That's why this sequence is really important to get the axial of the thorax of the baby in the Cine in the moving mode. And in this case, for the aortic arch, to obtain the view of the aortic arch, we draw a line from the middle of the aortic root to the middle of the ductus arteriosus. And of course, we can get also the ductal arch. And here is just like an images and overview. And we have from the upper part, from the left, the four chamber view. And then we have the three vessel trachea view, and then the plan on the aorta in this case, and then we have exactly two slices for the aortic arch to get the aortic arch, and we can see really nicely the aortic arch. And here in these final slides, in final section, I would like to include the attached figure from the article by Thompson and al. These images provide a comprehensive visual summary of the normal and abnormal variation of the three vessel view in a fetus with congenital heart disease. And these images illustrate the wide spectrum of anatomical variation of complete three vessel view observed in congenital heart disease. And the key message is that there is no single abnormal pattern, and the different CHD produce different configuration of the great vessel and aortic arch. So it's really important also for the clinician to be aware of that. So also the anatomy and the variation that you can incur also when you are planning the aortic arch, because we are always talking of something really, really small. And the last slide is just take home message of fetal cardiac MRI has important implication. A precise understanding of underlying anatomy is essential before imaging, and sequences planning as slice orientation must be adapted to the expected vascular configuration. Thank you to everyone.
Yeah, great. Thanks so much, Domenico, for preparing this presentation. Are there any questions for this presentation on the clinical application side? As Fabian said, of course, you're also free to ask questions during our talks or also in the end. So we are always very happy about feedback. I don't see anything in the chat yet. So then I think for the moment, I like to continue with our last speaker. Yep, which is Dr. Prashant Minocha from Ochsner Health Center for Children. So thank you very much again for being here with us and sharing your clinical cases with us. You are free to speak. Thank you.
Awesome. Thank you, guys. Thanks to Northh Medical for inviting me to present some of my recent cases at Ochsner. So for those of you guys, I know we have an international crowd, but I'm located at Ochsner Medical Center in New Orleans, Louisiana, and we have been doing a fetal cardiac MRI for just about a year, or just under a year, actually. So the clinical cases that I would be sharing today would be our very preliminary experience using SmartSync from Northh Medical and some initial experience using this technology. So can you see my slides?
Yes,
Yep.
we can.
Okay. So as has been covered by Leah and Fabian, fetal echo is the mainstay for diagnostic evaluation of fetuses with potential or suspected congenital heart disease. Gated fetal cardiac MRI can further delineate vessel anatomy, cardiac physiology, extracardiac structures that may impact prenatal counseling and postnatal outcomes, and also inform delivery planning and perinatal management. So this is a retrospective review of our initial experience in patients with congenital heart disease who were referred for fetal echo and fetal cardiac MRI with Doppler ultrasound gating in the 3rd trimester. We used the SmartSync from Northh Medical, and findings of fetal echo and MRI were compared. Our studies were performed on a Siemens 1.5T magnet. We had a total of 22 fetal MRIs with the Doppler ultrasound gating for the 10-month period. 12 with suspected congenital heart disease by fetal echo, and 10 had extracardiac indications for fetal MRI, and we had 2 volunteers. Gestational ages ranging from 31 to 37 weeks. Now, just to give some context, we had been referred, patients who had increased BMI, and a lot of providers referred these patients because they couldn't see very much by fetal echo, or they had poor acoustic windows by fetal echo. So in fact, the average BMI of our patients were 36.2, which is quite high in the scheme of things. It would classify as obese class 2. So these were the patients we had to work with, so we made the best of our substrate. So I'll be sharing these findings. So these were the clinical cardiac pathology that we were referred. Borderline left heart structure, suspected coarctation, unbalanced AV canals, hypoplastic left heart syndrome, tetralogy of Fallot, different flavors of tetralogy of Fallot with absent pulmonary valve, pulmonary atresia. We had some patients with heterotaxy, DORV, and transposition. So here's a patient with tetralogy of Fallot with absent pulmonary valve. The gestational age was 37 weeks, almost 38 weeks. So in the cine image here, you could see dilated RV overriding aorta with a VSD. In the black blood images here on the right, you could see very dilated branched pulmonary arteries, which we typically see with TET absent pulmonary valve. Here's a 3D rendering of the black blood volume, and these 3D volumes were created using the automated SVR function from Northh Medical. You can see a very dilated left pulmonary artery and right pulmonary artery. The left pulmonary artery is more dilated than the right pulmonary artery. And here in this image, you could see that there is some compression, at least the suggestion of compression of the left bronchus from the very dilated left pulmonary artery in this coronal black blood image. So we were able to also calculate fetal lung volumes using the automated SVR function, and we were able to define that the lung volumes were mildly hyperplastic to low normal. So I'm just going to present in each of these cases what we thought fetal cardiac MRI added, gated fetal cardiac MRI added. So in this case, we felt that the MRI was able to add, lung volumes. It was able to define that there was suspicious left bronchial compression, and we know patients with TED absent pulmonary valve typically have some component of tracheobronchial malacia. So this supported that theory, and then we were able to calculate or measure the dimensions of the branch pulmonary arteries, and the left pulmonary artery was quite a lot larger than the right pulmonary artery. So moving on to another case, another patient with tetralogy, pulmonary atresia MAPCUS, 37 weeks. In this cine image, you could see here, kind of starting in this axial image, you could see confluent branch pulmonary arteries, maybe a little MPA segment. It's a right aortic arch. And then you could see some small vessels coming off from the descending aorta, which we'd appreciate better on this coronal image. I was able to identify at least 3 small MAPCAs coming off from the descending aorta. And then, sorry, this is the 3D reconstruction. So you could see in blue these light blue, the small confluent PAs, and the MAPCAs coming off from the descending aorta, tortuous MAPCAs. So we were able to identify confluent mildly hypoplastic branch pulmonary arteries. By fetal echo, they weren't able to actually see the branch pulmonary arteries. So it was reassuring that we were able to see that by MRI. Made the diagnosis of TED pulmonary atresia MAPCUS just from the images suggested, and the color fluid Doppler pattern suggestive of tortuous small MAPCUS coming off from the descending aorta, but by echo we couldn't see the actual confluent branch pulmonary artery. So that was reassuring for us. And then by echo, no PDA was seen, and we were able to confirm that by fetal MRI. This is a postnatal CT, which kind of just shows that anatomy. So we're able to confirm, what we had suspected and determined by fetal MRI. Confluent PA supplied by, or small confluent PA supplied by 3 tortuous MAPCAs. Here's another patient at 36 weeks gestation. This was a really tough patient because this patient's BMI was really very, very high, and some of the echo images were limited. But on this patient who had suspected heterotaxy with right atrial isomerism, what was notable on the black blood images is that we really couldn't see the sort of the pulmonary veins coming back to the left atrium, or the left-sided atrium, which may be a little bit suspicious for TAPVR. So we got, as part of our routine protocol, we got cine images in the axial plane. And here in this axial cine image, kind of more superiorly, you could see there's a left-sided aortic arch. And there are a lot of circles here. So this is the right-sided SVC, and there was a smaller left-sided, this is the left-sided SVC, and there's a smaller right-sided SVC. And there's this small circle in the back here of the right-sided SVC, or posterior to the right-sided SVC. And the fetal echo had described that there was interrupted IVC. So we went looking and kind of scrutinizing the MRI data and MRI images a little bit more. And we were able to kind of determine that there was actually a left-sided IVC and a larger left-sided SVC. And then as we let this play, the aortic arch is unobstructed. And as we kind of go more rightward in this image, in this stack, you can see there's a right-sided SVC. So bilateral SVCs with a much larger left-sided SVC. And the images obtained by fetal MRI made me very suspicious for for TAPVR with a very dilated vertical vein coming across. So on the report and based on these images, we pretty much highlighted and flagged the case as being suspected TAPVR, supracardiac TAPVR. And this was confirmed postnatally. So you have a patient essentially with heterotaxy syndrome, DRV, pulmonary stenosis with right atrial isomerism and TAPVR to the larger left-sided SVC. In addition to the cardiac findings, we were able to define that there was a midline liver, right-sided stomach, asplenia. So all of these things were consistent with right atrial isomerism. And this is a postnatal CT kind of showing these findings. So here in this 3D CT reconstruction, you could see the veins coming back behind the left atrium. And then there was a significant vertical vein that drained the veins more superiorly, crossing the midline and then going into this more dilated left-sided SVC. So right SVC and left-sided SVC, and that vertical vein crossed between the LPA and the left bronchus. Despite crossing between the left LPA and the left bronchus, there was not significant obstruction postnatally. Here's another patient with detransposition of the great arteries, mitral stenosis, and pulmonary atresia. By fetal echo, there was suspicion for restrictive atrial septum. This patient was at 33 weeks gestation. So here you see the 4-chamber cine images, smaller left ventricle, larger right ventricle. And then you see that we're able to show that the atrial septum was somewhat leftward deviated, but there was no significant upstream dilation of the pulmonary veins on cine imaging or pulmonary congestion seen on the black blood images. Here you could see in the short axis plane a very dilated RV and a smaller left ventricle. The aortic arch was unobstructed, and you could see a ductus as well from the underside of the aorta. So what did fetal MRI add in this case? There was no secondary evidence of pulmonary venous obstruction, normal lung parenchyma. You could see a moderate-sized tortuous reverse-oriented PDA from the undersurface of the aortic arch, which supplied the confluent normal-sized branch pulmonary arteries. So that was reassuring in the setting of that concern for restrictive atrial septum prenatally by fetal echo. Here is another case of an unbalanced LV dominant AV canal with pulmonary stenosis. And this was at about 32 weeks gestation. Here in this apical 4-chamber of horizontal long axis image, you could see the dilated LV or larger LV with a smaller right ventricle. There was concern by fetal echo that there could be a coarctation as well in this patient, and the venous anatomy was not well defined, but in this black blood image you could see that the IVC was interrupted with azygous continuation to the right-sided SVC. We were also able to evaluate the aortic arch by black blood imaging, and the aortic arch measured sort of borderline, but there was no evidence of a discrete coarctation, and postnatally the arch was fine. So this patient had bilateral SVCs with a LSVC to the coronary sinus. IVC was interrupted with azygous continuation to the RSVC. So we were able to kind of define the venous anatomy with more diagnostic accuracy. So we diagnosed the LSVC that was not noted on the fetal echo, and we were able to kind of reassure providers that the arch seemed to be fine. So here's another case with an unbalanced RV dominant AV canal. Gestational age 34 weeks, 2 days. Here you could see the RV, LV with an inlet VSD. We're able to calculate the RV and LV volumes using the published data we had published in Colorado. And then here you can see the LVOT with that gooseneck deformity that is typical of AV canal. So what did the fetal MRI add? We were able to show that the LV was mildly hypoplastic, but was apex forming with a dilated RV, and the LV should be, despite being mildly hypoplastic, it should be favorable or adequate for a biventricular repair. And this patient is one of my outpatients that I follow, and had biventricular repair about 2 months ago and is doing very well. Here's another patient who had been seen fetally. There was a LV-RV size discrepancy and a question of a coarctation. This was scanned at 31, almost 32 weeks gestation. Here you could see in the apical 4-chamber horizontal long axis view that the RV was is a bit larger than the left ventricle, but the LV is apex forming. Here we were able to get short axis images to calculate volumes. And here you can see the black blood images just showing displacement of the left subclavian and a suggestion of a posterior shelf. And this patient did have coarctation postnatally, and we were able to reassure the team that the LV would be adequate. So this patient went on to have a coarctation repair, but had adequate LV size for biventricular circulation. We have another case here with DRV, large subaortic VSD, side-by-side vessels and RV hypoplasia with pulmonary stenosis. So lots of diagnoses, lots of anatomy here. And to add to the cardiac diagnosis, there was a concern from MFM that the patient had absent ductus venosus with a portal systemic shunt. So if the cardiac diagnosis was not enough. So this was a gestational age of 35 weeks, 4 days that this fetal MRI was performed. And here just showing the dilated left ventricle, smaller right ventricle. On this study, PDA could not be visualized by the fetal echo. Based on the black blood imaging and the synase that we were able to obtain, we were able to identify a PDA, and we were able to also, from an extracardiac standpoint, able to exclude a portal systemic shunt. So in this Sine imaging, this Sine stack, although it was a little bit blurry coming to the start of the stack, at the end of the stack, you could see this tortuous vessel here that's suggestive of the PDA, a very tortuous subigenous PDA that plugged into the right pulmonary artery. So how did this fetal MRI add to what we knew about this patient? We were able to identify that this patient had oligohydramnios with low lung volumes. The PDA was not well visualized on a recent fetal echoes, but we were able to see that small, left-sided PDA by MRI, and the patient had a right aortic arch. And we were also able to identify that the patient had no portal systemic shunt, and this was confirmed postnatally. So just to kind of pull everything together, gated fetal cardiac MRI is feasible in the third trimester. In our series, I provided very, very useful additional data, which was helpful in prenatal counseling, delivery planning, and informed postnatal prognosis. Obviously, we look forward to larger systematic studies, which would be needed to fully evaluate the impact of this technology. Our team is a small team. We do it with just, a few people, and I think it's very, very possible to do it with a small team. We don't have, significant support from research faculty, but we are able to do our work clinically. And I'd like to give special thanks to my radiology colleague, Dr. Vitter, and my other cardiology colleague, Dr. Moladu, and the rest of the techs and nurses who make this possible. So that's pretty much it from my end, but I'm here for any questions, comments.
Thank you, Prashant, so much. These were really great insights into great clinical cases, various CHDs, pathologies, and also looking at obese patients. Of course, again, feel free to ask some questions to Prashant. Now's your chance. Who wants to ask something here?
So we haven't seen something in the comments yet. Of course, maybe for the others, who is referring the patients the most? Like, where are they coming from? I think this is always a very, very interesting questions that I hear.
Yeah.
Can you maybe answer that?
Yeah. So I mean, I think a lot of the referrals are coming from my fetal cardiology colleagues. I also do fetal echo, so I would be lying if I didn't tell you that I self-refer. But I work closely with my fetal cardiology colleagues, so I think that there are definitely cases where we feel that we can't see things well enough, or they're very complex anatomy, which I think fetal MRI has been helpful. As well, we have a very close relationship with our MFM colleagues, and we work in pretty much the same space. So I've been lucky to have a lot of referrals from them as well.
Oh, perfect. We also hear of course about the reporting, because then there's always a report, but then are you doing this as a team together or are you writing this report up and then send it to them? Like, how is this process of reporting working for you in the hospital?
Yeah, so I work very closely with one of my radiology colleagues, Dr. Vitter. So how we read these studies is that we co-read from a radiology and pediatric cardiology standpoint. So I would look at the cardiac anatomy and the vascular anatomy. She would look at the extracardiac anatomy. And we actually often look at everything together, the extracardiac and cardiac anatomy. So we have two pairs of eyes on the same anatomy, and we co-read pretty much all of our studies. MFM is not involved in the reporting of those studies, but we do generate a single report that's available in the electronic medical record for their review.
Ah, perfect. Yeah, I think this is always very interesting to hear, right? Because once you have something, then the question is like, okay, how is it then transport all the information? How is it transported inside the hospital? And we have one question here as well about how you actually started the program. That was also a question that I wanted to have. So perfect.
Yeah.
And how you started your initial cases on pure research, or was it IRB, and how have you been able to actually pull this up?
Yeah, so we've been doing fetal MRI at our hospital for a long time, ungated fetal MRI. So, typical, extra cardiac assessment for brain anomalies, and so on and so forth. But we obtained the SmartSync Doppler ultrasound device from Northh around November, December last year. So it's pretty much been a year. And starting in December, actually, we started scanning patients. We had the plan to, I guess, at least do maybe 20 volunteers was a kind of lofty goal of mine before actually starting to do clinical scans. But we were able to, the thing is that obviously it requires funding to be able to scan volunteers, funding which we didn't have. So we ended up just pretty much going for clinical studies, which we were able to get compensation for through the routine fetal MRI CPT reimbursement code. And we started pretty much just scanning simpler anatomy, things like borderline left side structures, suspected coarctation, and then from there we progressed to doing more complex anatomy, things like the TETs and the patients with heterotaxy and so on and so forth. So I think it was not our plan to kind of dive straight into the complex anatomy, but I think that given the limitations that fetal echo had in some of these patients with poor acoustic windows, we felt that any additional information would be valuable information, because there was so little that was known, or not enough was known, that we felt that doing the MRI in those cases would be helpful. So I'm happy that we did, because we were able to learn so much with doing those cases, despite having patients with really very high BMIs.
Yeah. So basically without RAB, just with clinical question,
Yeah.
and then that leads also to the question a little bit. So I hope we could answer that question. If not, please have another comment, or we can also unmute you if you want. Then just write unmute.
Yeah, we do, just to add, Fabian, we do have an IRB now. We're looking, for funding to be able to do more kind of research, volunteer studies. So that's kind of where we're at right now in terms of expanding what we do. So I think the next step is going to be able to really bolster what we can achieve from a research standpoint.
Yeah, certainly. There's another question. If you also added patients where they haven't cardiac concerns, and you just added cardiac imaging, for example, I don't know, like fetal brain questions, but once you have them in the scanner, you just add some cardiac scans as well. Was it also, let's say, in discussion, or have you done that as well?
We have done that. With those patients, we have kind of added some cardiac sequences to just get some experience and be able to increase our kind of image optimization, because we had known from fetal echoes in several of those cases they had normal cardiac anatomy. So we have done that, and in our IRB structure, the goal is to be able to consent those patients to do the additional cardiac imaging.
Did you get consent from the mother then?
Yes, for the patients who are not clinical studies, pure clinical studies. Okay.
Yeah, great. I mean, you straight jumped into clinical questions. So how would you recommend the learning curve? Did you straight from the beginning get clinically results from image quality, or was it like, okay, and you needed like 4, 5, 6 scans until you have been there? And if so, what have been the main challenge?
Yes, I mean, I think it's been a lot of discussion. Domenico has been very, very helpful sharing sequences with us. And, I would very often text WhatsApp Domenico, hey, we had this case today. Can I do something differently? Can you share some sequences? So I'm still working on getting, better black blood. Just up to yesterday, I was speaking to Domenico about getting some help with some sequences. So I think using the fund of knowledge from you guys from North Medical and also other centers, people like Melenka, who also uses Siemens and has been working with scanning patients who have high BMI, finding out what her tricks are, reaching out to the other folks in San Diego who are also using Siemens and seeing what they do, and just it's a small community, so I think just relying on collective experience is helpful.
Mm-hmm. Yeah, perfect. Thanks so much.
Thanks so much, Prashant. So
thank you. Thank you,
There's
guys.
one last question: is how is post-processing done? The post-processing is done based on our post-processing software we offer on our homepage, actually. So you can request a login, and then you get the access. You upload your DICOM data, and then you can start the post-processing. Right now, it's for free. And if you're interested, just reach out to us. We can set you up with an account, and Sarah will also help you in getting started with him if you have problems.
Hi, great. In this moment.
There's Sarah. Okay, perfect.
That's
Okay.
amazing, yeah.
There's another quick question, but then I think how it links up to the scanner. For Siemens, in the case of Prashant, it uses the external trigger input of the Siemens scanner. We send the data from the sensor box, wireless to the connector box, and then you plug in just a cable into the Siemens scanner. Same thing for the GE. You also have a plug. You plug it into the GE scanner. For Philips, it is wireless, and for Canon and United Imaging as well. Then you don't need to use any wires. Basically, it's plug and play. So that's not a big. I think that's actually the easiest thing that we have.
Yeah. Okay, great. Thanks so much for asking so many presentations and ask questions. Sorry, and also answering all of them to Prashant and Fabian in here now. I just want to finish here saying a thanks to the Fetal Heart Society and also Society of Cardiovascular Magnetic Resonance. And thank you for all the ones who stayed until the end now here. Of course, we're looking forward to see you next year in 2026. We are already preparing our next webinar series because we also really enjoy, and we hope you enjoy too, to exchanging here on this platform. Of course, if you have any questions or feedback, you can directly reach out to me or to us at our info@Northh. DE email address. And from here, I wish you a happy holiday season. And thank you again.
Thanks so much,
thank you so much.
Thank you
for your
Thank you,
input.
guys.
Really, really appreciate it. Great cases.
Yes.
Thank you.
Thank you so
Thanks,
much.
guys.
Thanks.
Thanks.
Bye.
Have a nice day. Bye-bye.
Bye-bye.
Bye. Bye.